give them another 5 minutes, and then we'll be able to start. Thank you very much for your patience. You've learned how to live with technology, and sometimes it fails us. So today, as I had said, we'll be having a presentation on abdominal pain in children. And we'll be having this talk with Dr. Juliana Mwiva, who will take us through the management of children with abdominal pain. My name is Dr. Nancy Ngumbao. I'll be moderating together with Dr. Kailemia, who will take over the question and answer session. This event is CPD accredited, and you'll be able to get your CPD points after the presentation. For any queries concerning CPD, kindly email us at knetcpd@gmail.com or cpdpharmacy@gmail.com, and we'll be able to help you resolve any CPD issues that you may have. Thank you very much again. I'd like to hand over to Dr. Juliana Mwiva to introduce herself and begin the session. Thank you.
Good morning, everybody. My apologies for the delays that we have experienced starting this, but thank you for your patience. Thank you for keeping with us. So this morning, we want to talk about a fairly common presentation in our children presenting at this hospital. In Kenyatta National Hospital, we see patients both from within this region and also across the country. So without further ado, let's get right into it. Okay, so the presentation layout will be fairly straightforward. We'll talk about a case, a real life case that has presented in the clinic. We'll go through a few definitions. We'll talk about Rome criteria for functional pain. We'll talk about how we manage these children with functional pains. And then we will conclude the talk. So our case presentation, let me call this young girl Wanjiku. She's 11 years old. She comes into gastro clinic about 2 weeks ago with her auntie. And this is a child who's had 5 visits to our pediatric emergency unit. And each time the complaint has been abdominal pain. And the pain is located in the mid-abdominal area. Sometimes it is related to feeding. Sometimes the pain is present even without feeding. She describes this pain as being worse during the school term, but as we know, because of the coronavirus situation, schools have been closed for several months now. But in the 2 weeks prior to this review, the child has been having severe pain, even while at home. She says that her appetite is normal, and in fact, the auntie says that the child is growing well. And she says that her bowel and her bladder habits are normal. She also reports a headache whenever the pain starts. And in the course of these 5 visits to the PEU, she had been scheduled to do some tests, but she could not make it in as the mother was working. So she was actually even brought to the clinic by the auntie. So she reports some slight improvement with medications given to her at the PEU. Okay, and I think that this is a fairly common scenario that we see in our children across the board as we work through the presentation of abdominal pain. I'd like to just define what pain is. So pain is described as an unpleasant sensory or emotional experience associated with actual or potential tissue damage. In other words, it's an unpleasant sensation. It's something you know should not be there, but you're actually experiencing it. And young children, especially under the age of 5, cannot express pain adequately. So the parent or the caregiver is left to ascertain what exactly is going on in this child. What you find is, like, for the neonates, they cry, they're irritable, they refuse to feed. Okay, and then for the older children, sometimes you see dullness, you see irritability, you see changes in the sleep pattern, but the child cannot tell you what's going on, probably until they're about 6 or 7, when they can adequately express the sensation of pain. But even a 6-year-old cannot tell you exactly where it pains. They'll point towards the abdominal area, but they may not be able to exactly tell you, this is the spot that's paining. So most children under the age of 8 years are not good at localizing pain. And so most children will tell you it's in the umbilical area. And I think anyone who's handled a child in pain is going to know that, yes, there's a lot of pointing towards the umbilical area every time they're talking about abdominal pain. So how common is this problem? Well, surveys have been done in various parts of the world. Unfortunately, we have very little on abdominal pain in Africa. So surveys have been done in various parts of the world. Like in some Western countries, we had a study that was done across as a systematic review, and they found that up to 1/5 of children in school at any one time are going to be complaining of abdominal pain. So you can imagine 1 in 5 children sitting in a classroom are actually experiencing pain as they sit there. In the Netherlands, they look for what is called non-specific abdominal pain. So abdominal pain, all causes, any reason, and they found that this is happening as often as 25 incidents per 1,000 years of the children's life. And this problem was so common that at one point we had a pediatrician called Apley in the UK, and he took 1,000 children and he decided to run a survey across these 1,000 children and ask them, how often have you had any abdominal pain in the last 6 months? And he found that actually up to 30% of these children found that described an experience of having abdominal pain. However, we know that very often when children have abdominal pain, either their parents ignore it, or their parents tell them it's not that serious, or their parents find another explanation for this pain. And so what happens is that actually a lot of these children don't even talk about the pain that they're experiencing, because for them, the parent has normalized it. So what types of abdominal pain have we experienced? The pain can be organic, or it can be a functional pain. What is an organic pain? What does it describe? Basically, organic pains arise with specific illnesses. You may have trauma to the abdomen, you may have a specific infection, you may have a tumor, you could have intestinal obstruction, you could have other pathology that is occurring. So these conditions are going to present with a specific set of signs and symptoms that are well documented. And you can also run specific tests either in the lab, or you can do radiological tests that will help you in the diagnosis. Now, we understand that it is harder in children, especially under 5, since these symptoms are expressed secondhand through the parent or the guardian. But even as we run all these tests for these children, sometimes organic pathologies are found in as few as 10% of children with recurrent abdominal pain. What do we mean by recurrent abdominal pain? We are talking about a pain that is consistently and persistently expressed, and it has been going on for at least the previous 2 months. So that is what we mean by recurrence. We're not talking about the child who was well 2 days ago and comes into PEU today complaining of abdominal pain and vomiting. That child is in a different scenario. So when we look at all these organic pathologies, there are some things that are fairly common. Acid peptic disease, where you have problems of hyperacidity. And so we have children experiencing reflux symptoms. We have children vomiting. We have actually some children who even have peptic ulcer disease. We have infectious causes. In this country, we always look for things like amoeba and salmonella, and sometimes we find them. We have eosinophilic disease. We actually have children in our clinic in Kenyatta that we're following up for both eosinophilic esophagitis and eosinophilic gastroenteritis. We have diseases of the gallbladder. So that pain is localized usually to the right upper quadrant, and it is specific. We have pancreatic disorders, which also tend to present kind of like the acid peptic disorder. And this kind of pain is actually brought about when the child starts to eat. Then we have very many other things. We have surgical disorders. I'd like to talk in particular about an intussusception, especially with that clinical, there's a clinical criteria. This is a child usually between the age of 6 to 18 months, presenting with spasmodic abdominal pain, stools that are coming out, a little bit of blood and mucus in that stool, yeah, and sometimes fever. And then in between these attacks, the child tends to go back to normal, but over a period of time, we are going to see a decline in the condition of this child. Appendicitis, likewise, right lower quadrant. We even have non-gastrointestinal disorders that can present with abdominal pain. We have seen children presenting with right lower quadrant pneumonia, and then it actually presents as an abdominal pain. I would like to talk about the ureteropelvic junction obstruction, because this is a common condition that occurs when you have an abnormal kink between the pelvis and the ureter. And you may not often see this. So what tends to happen is you want to ask your radiologist to do the scan and then allow the child to drink some fluid and come back and repeat the scan. And come back and repeat the scan in about 10 minutes time and just see if now they're going to see ballooning of the pelvis, of the renal pelvis. So those are the things. Diabetes mellitus, we have our kids coming in with AKI and they actually present in severe abdominal pain sometime. And then we get into the functional disorders, which is where we're going to next. Okay, so functional abdominal pain. As I've mentioned before, 10% of children in one study who were screened were actually found to have no pathology. But they are consistently complaining of abdominal pain. So pain is said to be functionable when it is without demonstrable evidence of a pathological condition, such as an anatomic, metabolic, infectious, inflammatory, or neoplastic disorder. And these conditions occur according to a specific set of signs and symptoms. So you have taken the history, you've examined this child, you've done even a few baseline investigations, everything seems to be okay in this child. So then we start to classify this pain as a functional pain. Now, common factors are seen across the board in children with functional GI disorders. These are children usually above the age of 5. So we want to take the complaint of pain a little more seriously in a child who is under the age of 5 years. Towards adolescents, females tend to present more often with abdominal pain than males do. There are a lot of psychosocial factors in this family, and we're going to discuss that one a little bit later. And then there are other family and cultural influences that impact on the presentation of these children. Again, we are coming to this in a little bit. So, people were trying to understand. Now, we have a group of children. They are complaining of pain. For them, the pain is real. However, we don't know how to classify this. So the European Society of Pediatric Gastroenterology, Hepatology, and Nutrition met in Rome in the early 80s to form a group, to form a working classification for these functional pains. And they came up with what was called the Rome criteria. Since then, they have been meeting in different places, but the name Rome criteria carries forward. It's currently in its 4th revision. And what they agreed is in the current Rome criteria, Rome 4, is that this child has experienced those persistent symptoms for at least 4 days a month in the previous 2 months before the time of presentation. And this applies to most of the criteria. We'll go through a few exceptions where it does not apply. In the Rome 3 criteria, it also said that the child should have consistently experienced these things for at least 6 months prior to being reviewed in the clinic. So what they did is that they divided the children into the small ones, the infants and toddlers, and into the older children and the adolescents, because we find certain syndromes seem to occur more frequently around that. So we have the functional nausea and vomiting disorders. So remember, a functional pain is where you have looked at this child, the symptoms they're presenting with are not fitting in any one particular disorder, and also your baseline investigation is essentially coming back as normal. So in these functional nausea and vomiting disorders, you have the cyclical vomiting syndrome. In cyclical vomiting, we have the presentation of a child. They are usually above the age of 2 to 3, so they're not very young. And these children can start vomiting one day for no apparent reason. And the vomiting is such that it is as many as 10 to 12 episodes in 24 hours. They cannot seem to control it. It will go on and on and on until we administer certain medications like ondansetron. And then we put the child in hospital, we give symptomatic treatment. Within a day or two, the episode is able to be controlled. Sometimes episodes last for a week, especially when you delay the intervention. In between episodes of cyclical vomiting, the child is perfectly normal, is eating everything as usual, is going to school and behaving as normal. So that is one. We have functional nausea and functional vomiting as well. And these are episodes that occur almost regularly. We're having like this happening every week. We have rumination syndrome. Now, what happens in rumination is that you actually have a child who will chew their food and then bring it back into the mouth. They will chew, swallow, and bring it back into the mouth. And they're not vomiting. They just have found a way of bringing back those contents from the stomach into the mouth. Then they will chew it again and swallow it. We don't tend to see this in children very often, except in children with cerebral palsy. So please look out for this one. And then we have aerophagia. You have a child who, when they wake up in the morning, the tummy is fine, but by midday, they have a very big, very bloated tummy, and it is thought that these children are actually swallowing air. We have functional dyspepsia, where a child complains of abdominal pain, generalized, associated with bloating, and when you press on the tummy, it's a bit tender. We have irritable bowel syndrome, and the hallmark of irritable bowel is that you have alterations in your stool patterns. Then these occur anything from diarrhea to constipation to alternating between the two. We have something called an abdominal migraine. An abdominal migraine it's a rather interesting presentation. So what happens in abdominal migraine is that you actually have a child who presents with abdominal pain. The pain has a prodrome, kind of like you get with a migraine and the headache. So the pain has a prodrome, and the child can tell you that, yes, it's about to come on. I feel like they just feel strange. And sometimes you can see them sweating. Muzungus are described as going pale, and you can see them restless. And then before too long, they have this abdominal pain. It's dull. It takes over their life. They're unable to do anything. Attacks can last for 1 hour. Rarely do they get more than 2 attacks in a day, but these attacks can come at any time. They can last for more than an hour. Then after the attack, the child slowly recovers and comes back to normal. So it kind of behaves like a migraine. And the interesting thing about these children is that there's usually a history of migraine in that family. So you need to get into the family history as well. And sometimes there's just this abdominal pain. You cannot otherwise specify which condition it is, like our case presentation that we presented before. And then there's a functional constipation, and there's the non-retentive fecal incontinence. What actually is that? That is a child who presents and the parent says, this child is passing stool on him or herself. This child says they are not aware when the stool is passed. When you check, the child does not have features of constipation, but this child is not able to control the passage of stool. Interestingly enough, for a lot of these children, stool is not passed in bed. It's usually passed during the daytime. For functional gastrointestinal disorders in infants and toddlers, we have, I think every pediatrician, everybody working with children has had the opportunity to manage a child with colic. And colic is something that even now is still not well understood. We have a child within a few days to a few weeks of birth who begins to cry. The crying is usually in the evening. The crying does not affect the feeding, but it definitely affects the child's comfort, and it affects the guardian's comfort, the mother as well. And these episodes go on for a month, 2 months, and suddenly they fade away. So we're not even sure why those episodes happen. There are all sorts of theories about that. I don't want to get into that now, but it is now classified as a functional gastrointestinal disorder in infants and in toddlers. We also have infant dyschezia. So what happens is when babies are born, we have a very active gastrocolic reflex. So what does that mean? They'll feed a little, you will see something coming out on the other end. At the point of about 2 to 3 months, we lose the automatic gastrocolic reflex, and now we move on into self-regulated passage of stool. So what happens in that is that for a baby to pass stool, the abdominal musculature must contract and exert internal pressure, and then you must relax the pelvic and the anal sphincter. And sometimes babies are not able to well coordinate that. So the child wants to pass stool, the stool is soft, but the baby is folding up their legs and they're crying and they're trying to coordinate this to get the stool out. And it takes a while for that to go through. For most of the time, you don't actually need to do anything. We teach the mothers how to comfort the baby, how to massage, and how to encourage increasing abdominal pressure and relaxing the sphincter by bringing the knees up into the abdomen. We also have babies with rumination. Cyclical vomiting has occasionally been reported in infants as young as 1 year. And we have the functional diarrhea, the so-called toddler's diarrhea, and constipation being fairly frequent in this age group as well. So how does functional pain start? In essence, it is thought that there is a normal process occurring in normal bowel or bowel that has been slightly altered due to a previous pathological process. And now, for one reason or another, we have increased sensory perception of these processes. And then this is regulated through the spinal cord to the brain, and that comes back in a feedback cycle. So actually what you're seeing here, you kind of have, it's going to be a continuous feedback loop between the brain and the gut. So both the enteric nervous system as well as the central nervous system get recruited, and you have this continuous feedback cycle that is set up for this child. What happens in the gut? So whether the initial process was an infection, inflammation, whatever it was, trauma, something, we have a gut that now seems to have slightly increased release of substances that are nociceptive, such as substance P. You have altered release of the serotonin-like molecules, and where you have inflammation, you could probably have release of cytokines coming in, and all this causes inflammation within the gut, but more importantly, it acts on the nervous system, on the nerve endings within the bowel wall, and then this arises in the sensation. You actually have an increased sensation of pain, even with normal processes. We also know that children with abdominal pain have been shown to have a slight increase in the motor activity, especially the migratory motor complexes. Now, your bowel is never really at complete rest. When you eat, you have an increase of bowel movements. But even when you are completely at rest and you haven't eaten for some time, like say in the middle of the night when you are asleep, we still have some migratory motor complexes occurring about 3 every hour, and they propagate. They propagate from the upper to the lower all the way through. So we have those that motor activity happening. And when you have abdominal pain, you might find that some of these children are actually getting an increase in the motor activity that is going on in the bowel. As I mentioned before, these children also have a lot of psychosocial factors. If you look at them, they tend to be timid, nervous, anxious types when they come into the clinic. And a lot of these people are overachievers or perfectionists by nature. And what do I mean? We commonly joke with my fellow gastroenterologists in the clinic that when we see our babies, we never get to see the person who is number 35 out of 35 in class, but we always see the ones who are between number 1 and 10. So they tend to be children who are kind of internally driven, and they have a lot of internal, pressure within themselves to achieve certain targets. So they have a lot of internal stress. These symptoms seem to occur more commonly if you're a firstborn or if you're a lastborn. And also, if the home you come from has some issues, there's marital discord, or you have parents who are excessively harsh. And I think in Africa, we have a lot of parents who are excessively harsh. They talk badly to the children. They never want to listen to their children. In the Western world, we have the opposite. We have parents who they let the child do anything and everything. So this child has no boundaries. So this child now develops anxiety because they don't understand within what boundaries am I operating. As I've mentioned, their family attitudes towards illness. So you have like a parent who will sometimes tell a child, ignore it, leave it alone, there's nothing wrong with you. You even went to hospital, there's nothing wrong with you. So those attitudes tend to actually make the child feel like there's something wrong with me and they cannot figure this thing out. And also if you have a parent who is anxious. And I think one of the biggest challenges of managing children with functional pain is that sometimes the parent anxiety feeds on the child's anxiety, makes the child more anxious, makes the child more aware of what is going on. And then now, when the child is having more pain, the parent is even more anxious. And it becomes this feed-forward cycle. Now, let me talk about affluence, because affluence is a fairly controversial concept. Affluence means that a child can grow up in an environment that is completely sterile, everything is clean, everything is presented to you well, okay? But it is thought that the GI system, and this is a topic for another day, but it's thought that the GI system needs a few challenges in life to begin to form a balanced interaction between itself and the gut microbiota and the food that we eat. So when you grow up in affluence, you don't actually get enough challenges and you start getting prone towards developing some of these abdominal complaints, the worst of which is inflammatory bowel disease. And also, we do know that functional symptoms occur a lot more often in children with depressive disorders, with anxiety disorders. Now, I'm not talking about just being anxious. I'm talking about a child who's been recognized to have an anxiety disorder, and in children with attention deficit hyperactivity disorder. Oh, that slide is not clear at all. Okay, anyway, what this slide is just trying to say is that with psychosocial stressors and altered GI physiology, you are going to have an episode of pain, and how you handle this pain then determines what happens. If you are supported, if your symptoms are recognized and they're dealt with, then you're probably going to adjust to your symptoms and you're going to be able to handle it and move on. But if your symptoms are not well handled, if you come from an environment where you don't receive the right response, you're probably going to develop a maladaptive response. My apologies for the lack of clarity there. So how do we investigate abdominal pain in children? History taking. As we say in medicine, history is 60% of what you make in your diagnosis. History taking must be done. And when you take history, if you have a child, even a 2-3-year-old can tell you sometimes what they are feeling. And they will tell you in their language. Kindly allow that child to express themselves. Okay? Because you actually get a lot when you hear the child talk, and you also get to watch the interaction between the child and the parent as they're talking, because sometimes parents want to tell you everything. They tell you, this child came like this child we have done this child we've gone where, this child. Then when you ask the child, how are you today? I'm okay. How are you yesterday? I'm okay. How are you last week? Sio vibaya sana. But mommy is the one coming to tell you all the things. You must be able to allow the child to talk for themselves. Make sure you include a family medical history. Why is this important? If you have a family history of inflammatory bowel disease, if you have a family history of autoimmunity, you have a family history of diabetes, you have a family history of cancer, you have a family history of polyps, there are certain things that need to be brought out when you're taking your history. So kindly get details of the family history that this child comes from. Note how they're interacting with you, all of them as a family unit when they present. In the first case that we presented, this is an 11-year-old girl who came in with her auntie. And the auntie sits over there, this girl sits over here. And when she sits on this side, she's busy twiddling with her fingers, she's looking down. She tells the auntie to talk, but when I ask the auntie some questions, she doesn't know because auntie came from wherever, picked her up and brought her to hospital. Mom is a single mom separated from the dad, and this auntie who is present in the interview is the sister to the father. So you can already see that discord. Where is mom? Mom, of course, in these tough socioeconomic times, she works as a house help. She goes and comes in the evening, and she could not get an off to come to the clinic. And apparently when she comes home, like on a Sunday now, instead of spending time with this child, she just wants to rest in the house. She tells the child, go and do whatever you're doing, leave me alone. So you can already see what was going on in that family. Where possible, you try and examine, and you need to do a thorough head to toe examination because every system has an impact on this pain that the child is feeling. And look out for what are called red flags. Now, let me tell you what these red flags are. So, if you have a pain described and examined to the right upper or the right lower quadrant, that is a very specific pain. That pain needs to be dealt with. If you are having blood in the stool or blood in vomitus, again, blood coming out of the GI is not normal. That is a pain that is probably organic. If you have a child who has consistent weight loss experienced over the last few months, that child has a significant problem. Likewise, if you have slow or delayed growth, and if you're in puberty and you have not yet, your stages of puberty are not yet achieved according to schedule, there's a problem. You have painful swallowing, or you have difficulty swallowing. So you need to get into the history of eating. So if we have a child who is complaining, I can swallow liquids, but my solids are getting stuck, that pain is not normal. If you have persistent vomiting, by persistent vomiting, I mean you have more than 3 episodes every week, you're going to vomit. And it will happen across the board, no matter what you're eating, no matter what else is happening. That is abnormal. Again, as I mentioned, we must take a family history, look for inflammatory bowel disease, celiac disease, look for tumors, get into any other multisystemic disorder, diabetes mellitus, and all the others. If you have a child with fever, then that pain is not normal. If you have a child with arthritis, then it leads you to ask, are we dealing with, perhaps you're dealing with SLE, we're dealing with one of the other syndromes, so you need to look out for connective tissue disease. In our background, in the smaller ones, you have a child with a painful abdomen, they have painful hands and feet, look out for sickle cell. If you have perianal disease, you have skin tags, you have fissures, you have fistulae. These things may occur in constipation, but more often, you need to be aware, look out for features of inflammatory bowel. If you have jaundice, that pain is not normal. And if this child is waking up at night, now in the ROM3 criteria, nocturnal awakening was shared as a significant finding in a child who has abdominal pain. In ROM4, they realized that children with the anxious personality type will often wake up at night. So it still remains controversial, but it is a symptom worth looking out for. And then what do we do when we have these children present? So you've investigated, you don't feel like this is a surgical problem, this doesn't look like any one of the other medical conditions. So you just want to have an idea of, are we missing something? It's always useful to do your full blood count. You get an idea of whether you have sepsis, whether you have an inflammatory process. Have a look at your UNDs. Have a look at your liver functions as well. For people in other hospitals, kindly include a total protein and an albumin. The presence of a low albumin indicates that the child may be you might be dealing with an inflammatory bowel disease. So have a look at that as well. Do your inflammatory markers, do your CRP, do your ESR as well. They're always useful. If they're elevated, let's work up a little bit more for infective or inflammatory diseases. Always have a look at the stool. Do stool microscopy, culture sensitivity, and even if the child has not complained of blood, have a look at occult blood in the stool. Have a look at the urine. Sometimes we have UTIs and we're not aware of them. Always have a look at the urine. If you can, do an abdominal ultrasound. And if you find that you have done all these things and across the board, the child is actually registering as normal, then you can actually relax a bit and say that perhaps this pain is more functional than pathologic. Now, children with a known GI disorder, like inflammatory bowel disease, may still have a functional disorder. So in inflammatory bowel disease, we know that you present with a symptom, you have symptoms of altered bowel habits, sometimes you have blood, but sometimes these children just come with pain, they're always in pain, you're not quite sure what is going on. Sometimes they have dyspepsia, they have heartburns, you're not quite sure what is going on. They can still have functional disorders because of the stress they encounter dealing with this other problem. So how do we take care of children with functional pain? This is now where we talk about the biopsychosocial model. In traditional medicine, if you look at the circle that is on the left of the screen, in traditional medicine, we aim for number one only. We just aim to know what disease is this. And therefore, if I know what disease is it, I can prescribe the right treatment and the child should get better. That is your traditional medicine. In functional disorders, we are aware that with each presentation, there'll probably be a disease past or present. There'll be a psychological disorder. There will be those functional symptoms that have brought the child into hospital, and there may be a lot more somatizing in that disease process than is normal. And sometimes these symptoms can be just because of a normal physiological process in the baby. And then there is probably those psychological factors between this individual internally and this individual and the people they're interacting with. So treat the patient and the illness, try and address the suffering rather than just diagnosing the disease. Acknowledge that this pain is real, okay? It's not imaginary. You can imagine when you have a tension headache, yeah, and someone is telling you, no, you don't have any problem. No, you know you have a problem. You know you have a pain, but you also know that when we do all the tests, we will not find anything. When you have like a stitch after running a bit, you also know you have a pain. If we do a scan, if we do X-ray at this time, we're not going to catch anything, but we know that you have a pathology. And then once you have identified which particular functional problem it is, put it into one of the room 4 criteria. And the beauty of doing this, especially in the age of the internet, is you tell the parent, your child fits this criteria. And they go and look at it for themselves and they read about it and they feel much more reassured than trying to tell them, no, I'm not sure what is wrong with your child. It could be serious, but let's do CT scans, let's do I don't know what else. Those things are not useful. Advise the parents that the majority of children are going to recover with appropriate support and a minimum of therapeutic interventions. We do not want to run this child through 1,000,001 endoscopies, CT scans, I don't know what else we can do. Just tell the parent, this child is probably going to be okay. So when you're looking at the complete biopsychosocial conceptual model, we have things that have happened to this child in early life, the genetics, the culture they grew up in, the environment, and things such as trauma, previous infection, and parental behaviors. This can lead to psychosocial factors such as the stress, personality traits, coping, cognition, and social support. And you also have between the gut enteric nervous system, abnormal motility or normal motility that is abnormally being recognized in sensory disorder. You can have an immune dysfunction, altered microflora, and changes in the way the child is eating. This now results in a functional disorder, and this results in a child who is frequenting the healthcare system, whose daily function has been affected. She's not going to school, cannot even do 1, 2, 3 because quality of life now is affected and has increased healthcare costs to the parent. And now, when the parent is stressed, that anxiety goes back to reflect on the same child. How do you treat? Reassure them. Reassure them. If you have done your baselines, tell them this child will be okay. Even if they're in pain now, this child will be okay. And then you set a plan with the parents and guardian. And if you have an older child, with this child. Talk about life coping skills. And if you are not well trained to do this, kindly refer them to a psychotherapist who can help them develop some of these life coping skills. Look for a child who is taking advantage, whether unconsciously or even consciously, of their pain. We have children who would much rather be in hospital than attending school because they're trying to escape some stress in school. We have children who pretend to be sick so that their mom or their dad can spend time with them in the house. Look for those gains and form strategies to address them. I'm not saying force the child back into school, or in this other case, tell the mother to go back to work, but find a way of addressing it so that the child is comforted and is able to resume life. Diet interventions. Reduce the lactose content. You can reduce it all the way to 0. Reduce the fructose content as well. Look for how to increase dietary fiber and have a regular feeding schedule. When we talk to a lot of these children, by the way, they don't actually seem to be eating regular meals. They don't seem to be eating as a family. Such simple things are actually important in increasing the comfort of the child. We'll talk about psychotherapy. We do pharmacotherapy. Please note that that is point number 7. And then we also talk about how to improve school and exercise and to improve school attendance and improve on exercise. Now, children with pain just want to sit in the house and sit and think the whole day about what they're going through. Talk to the parent or guardian about engaging them in activity rather than having them sit in one place and focus on themselves. Psychological therapy. A lot of us are not trained in psychotherapy, and I'm not talking about psychiatric intervention. I'm just talking about simple cognitive strategies. Cognitive behavioral therapy has been shown to have excellent outcomes in terms of abdominal pain. In some children, this alone, without pharmacotherapy, has actually been enough to handle the pain syndrome. We can also teach them relaxation techniques. We are not very familiar in this country with hypnotherapy, and also encourage the child to keep a diary of their symptoms, when they occur, and what they were doing as that symptom occurred. And actually the child begins to understand, like when I go to school and today I had maths and the teacher shouted at me, that's when the pain came. And you as a parent now, you can actually advise the parent, come and talk to the maths teacher. This pain is coming all the time when the child is in the maths class. Pharmacological therapies, as I've mentioned, please don't start here. Please start at point number 1. But if you need to give pharmacological therapy, especially in these children, just be aware that there are not that many therapies that have been shown to have benefit. Now, the H2 receptors and the PPIs can be useful in short term. Our girl in this case had been put on omeprazole and she had responded mildly, but after 2 weeks of the omeprazole, the pain was back again. So it is not useful in the long term. It may be useful in the short term as you get the child working up in psychotherapy and in other strategies. Drotaverine has been used. Drotaverine in this market, I think, is marketed as Nospa. So it's been shown to have some benefit in a few children. What has been consistently shown to have benefit, whether by placebo or by actual reduction of inflammation in the bowel, is peppermint oil. So advise parents to give 2 to 3 drops of peppermint oil in the child's food or in tea 3 times a day. And it's actually been shown to be useful. Hyoscine, otherwise known as Buscopan in this market, doesn't actually have a lot of studies in functional gastrointestinal pain. Now, when they come to our office, sometimes we put them on the antidepressants, both low-dose amitriptyline and serotonergic agents, such as the standard SSRI or even the citalopram. You need to use these medications
Hi everyone. It seems as if we've lost the presenter a bit. Let's try and get them on. Hi everyone. Thank you for your patience. Their internet had dropped a bit, but they're reconnecting. So we'll be on live again in the next 1 or 2 minutes.
Okay. Hello.
Hello, we can hear you.
Oh, okay. Sorry. We've gone on to a mobile phone, so I'm really sorry about that. My apologies, because I realized I finished the presentation, and I think the last 3 or 4 slides did not come through. So I'd like to take questions, and I don't know, Dr. if you'd be able to read them out, or do you want me to just talk through the last slides?
You can talk through the last slides. There have not been any questions on my end.
Okay. All right. So I think we left off when we had just looked at the biopsychosocial model, and we had talked also about the treatment of functional gastrointestinal disorders, which was largely reassurance, setting the therapeutic plan, advise on life coping skills, look for gains from the illness and form strategies to address this, modify the diet, psychotherapy, pharmacotherapy, and then exercise and school attendance. And we had talked about psychological therapy being cognitive behavioral therapy, which, as I wanted to emphasize, is largely about a set of skills that teaches you how to develop mind control techniques, relaxation techniques as well, and hypnotherapy, and helping this child keep a diary of their symptoms so that they are able to be in control of what they feel and experience for themselves. Pharmacological therapies, we talked about the H2 receptors and PPIs. They're not shown to have a long-term benefit in the functional disorders, but they may be used in the short term as you work the child towards the other therapies. Antispasmodics, we have shown benefit from drotaverine and peppermint oil. 2 to 3 drops given with tea or with food 3 times a day has also shown to be very useful. And then we talked about Buscopan not being well evaluated, and also the tricyclic antidepressants. We use low dose amitriptyline for a period of 6 to 12 weeks with good results, and serotonergic agents as well, like citalopram. And then we have the probiotics. And what we see with probiotics is there have been a few studies which show some improvement in symptoms, especially in infantile colic. With infantile colic, lactobacillus GG has actually been shown to, in 3 separate studies, has been shown to demonstrate an improvement in the symptoms. Lactobacillus reuteri has also been shown to have improvement in abdominal pain symptoms in small trials. Bifidobacterium species had shown improvement in irritable bowel syndrome symptoms in adults, but there is no current consensus on the use of probiotics. Why we think probiotics may be beneficial is because they actually have a positive effect on intestinal inflammation, and we know that the presence of probiotics reduces the presence of undigested carbohydrate within the bowel and allows these children, it actually breaks down those carbohydrates into smaller oligo sugars, which now allows the child to experience more comfort in their bowel. In terms of outcomes, 30% of these children within a year may have resolution of symptoms, and up to 50% of them will have permanent resolution of symptoms before adulthood. And outcomes are always better in those who have received psychotherapy versus those who did not receive psychotherapy. And children will frequently display more depressive disorders. When you look at these children as a group, as they grow up, they have more incidents of depression, more anxiety, and they tend to have a lower self-esteem than their peers, especially when they're adults. And the frequent school interruptions also result in poorer outcomes as well. So in conclusion, childhood abdominal pain is a very common presentation to the healthcare system at all levels. A majority of children will need a minimum workup and will fall into the functional abdominal pain category. These children can be best managed with lifestyle interventions and psychotherapy. And when you are in doubt, kindly refer. Don't do an extended workup. Just refer these children to the gastro clinic, and we will be happy to see them there and take care of them. Once again, I wanted to say thank you for the online community for paying attention. And I would like to welcome maybe 2 or 3 quick questions.
We will also organize in Kenyatta to see how to get the slides across to the people who have attended the session.
Thank you very much for your presentation, Dr. Mwiva, and our apologies for the internet connection issues. I'm very glad that you could give us a presentation, and I'm sure a lot of us have really appreciated the presentation. Dr. Kailemia, will you take the question and answer session?
I am using Dr. Kailemia's phone, so she might have difficulty with that. So just read them out. We'll take 2 or 3 pressing questions because of the time.
So I think the questions that I have here is from Salima Jor, and the question is, what's the recommended duration for the low dose amitriptyline, and what dose do you?
Okay. So when we talk about low dose amitriptyline, in children, we're talking about a dose of 10 to 25 milligram, which is given once a day. We prefer to give this at night because amitriptyline is sedating. Imipramine and I think it's called desamitriptyline or something like that, are less sedating, and so you can consider giving those during the day. But amitriptyline itself is a sedating drug, so we recommend it is taken at night so that the child can sleep it off and wake up in the morning. A fair trial of amitriptyline is about 6 to 12 weeks. However, for a child like that, kindly make sure that they have started psychotherapy. I wish to emphasize that we do not move on to pharmacotherapy without starting the other steps in the program, because pharmacotherapy on its own has not been shown to give a sustainable outcome in these children. So we want to recommend that 1, you have started the psychotherapy. 2, if you feel like there's a deeper underlying disorder, such a child should be referred to the psychiatrist. And then number 3, if you are following up the child for that extended period of time, we would be happy to have at least 1 or 2 visits with them to be able to assess their condition as well.
Thank you very much for that.
Okay.
There's a question on infantile colic, and I'm not sure whether that's also part of the functional abdominal pain, but the 2 questions are from an anonymous attendee and Caroline. If you could touch a bit on infantile colic and how to manage.
Okay. All right. So yes, infantile colic is actually part of the Rome 4 criteria for functional gastrointestinal disorders. Infantile colic, as we've mentioned, is just these bouts of crying, discomfort, restlessness. Usually the child is not febrile, but is very irritable, and they seem to occur at a certain point during the day. As we have said, the pathophysiology is not well known. We think it is perhaps an interplay between adjustment of the mucosal lining, maturation of the digestive process, as well as new neuroendocrine pathways and gut endocrine to brain pathways. So there are all these things going on at this point in time. And then finally, it seems that as the adjustment occurs, the baby is back to normal. So various therapies have been tried. We have tried exclusion diets, both in the baby and in mother. We have tried probiotics in baby and in mother. We have tried various analgesics in baby and in mother. I mean, we even have sometimes recommendations from different authorities that if a baby is too much, admit mother and baby to hospital and sedate both of them and keep them in bed. That I think is the extreme recommendation. However, what we do know is that 1, reassurance. You tell the parent that we have examined, we are almost fairly certain that there is nothing wrong with this baby, and it is a time limited process. And then you may try anything from the gas form, what are they called? Simethicone and the group, where you actually try and control the presence of gas within the bowel. You may try anything from the probiotics. We have a lot of herbal concoctions in the market that are being marketed as suitable for infantile colic. We don't have case control studies or even double-blind studies about these products and their safety profile, and also whether they are useful in infantile colic. So at this point in time, there are no strong recommendations other than reassurance and, of course, removal of any obvious irritating factors in the baby and the mother's diet. That's basically what we have for them.
Maybe the last question, even as we come to the end of this webinar, there's a question here on the safety of pylori kits in children, because they're seeing prescriptions of the H. pylori kits being given to children.
Okay, thank you very much to the person who has brought up the pylori kit. Let me just state that H. pylori in children is a very common occurrence. And actually, if you would take a population of children out in the community without any symptoms, we would expect to find 40 to 50% of them are positive for H. pylori. So when you have H. pylori in stool in a child, that does not mean that the H. pylori is the cause of the pain in this child. I would like to emphasize that because patients frequently come, they have been treated for H. pylori 2-3 times. The pain comes back immediately, or even sometimes it persists while on treatment. And then the parent is wondering, okay, which medicine should I buy to take care of this H. pylori? Number one, H. pylori is a topic, it's a complete topic for another day. And I think we need to organize a seminar on that one as well. I think it is over-tested, over-treated, and it is actually not the sole etiology towards abdominal pain in these children. And when you give a child the adult kit, remember in pediatrics, we tend to calculate our drugs based on weight. So we do not want these children on an adult kit, which is a standard dose cuts across the board for everybody. Also in pediatrics, we may have a difference in treatment regime as compared to the current adult regimes. So my recommendation is do not give a child a kit. Kindly, if you're fairly certain that the H. pylori is the cause, then one, refer the child. We would prefer to do endoscopy on such children. Two, if we find the H. pylori, we tend to do a combination treatment that we prescribe ourselves rather than prescribe a kit. So kindly avoid kits where possible.
Thank you very much for the answer to your questions. And I think we've actually come to the end of this webinar presentation. Maybe your parting remarks, even as we come to the end.
Yes, so I think functional pain, abdominal pain is a very common complaint in children. You need to look out for red flags. You need to look out for the common syndromes that occur. We've gone through some of those. If you have a child that doesn't fit into any one of those, but is still experiencing pain, you need to think about the possibility of it being a functional pain. We need to work up the child in that. And if you have any doubt, kindly always send these children for further review. We would be happy to take them. We would be happy to deal with them. Thank you.
Thank you very much. And thank you to all our participants who stayed on until the end of this webinar presentation. And thank you so much, Dr. Mwiva, for enlightening us about how to manage functional abdominal pain in children. And I'm sure it's it's quite a common problem that as healthcare workers we see. Again, as I had said, for any CPD queries, kindly email us at knetcpd@gmail.com. Otherwise, thank you so much and have a lovely day. Thank you.